Great, and we're back.
All right. Thank you to our Ask the Hematologist panelists. We'll get right into it. If you guys want to go through it and just do a quick introduction, I know you may have been up here already, but just letting everybody who may be new to the session know who you are and where you work.
I'm Marshall Mazepa. I'm a hematologist at the University of Minnesota.
Hi, I'm Ming Lim. I'm an adult hematologist at the University of Utah.
Hello, I'm Ara Metjian. I'm an adult hematologist at the University of Colorado.
Great, thank you. So we'll just get right into the questions. This will be a variety. This is kind of a catch-all section where if your question doesn't fit into one of our sessions, it'll hopefully fit in here. So the first one is there any research garnered from the COVID and sickle cell interaction that may be useful in the treatment of TTP? Actually, it's not the interaction between COVID and sickle cell, it's just any COVID research or sickle cell research that may be useful in the treatment of TTP.
I don't think there are any direct relationships between those diseases and TTP. I mean, I think there is a connection between sickle cell disease and TTP in that people have seen during sickle cell episodes, there can be the big sticky protein, ultra large von Willebrand factor. So there is ongoing work to try to understand whether giving patients with sickle cell disease ADAM-TS13 is helpful. With COVID, most of the work that overlaps in our fields has been related to the risk of blood clots in large blood vessels, primarily in the veins, whereas TTP is a disease of blood clots in tiny blood vessels. And then with regard to the vaccine, we've seen hematologic complications as well that have been mentioned. But I don't think the lessons we've learned so far, at least from treating patients with severe COVID or sickle cell disease, has directly impacted how we treat or how we might treat people with TTP. But that's my take.
I'm not aware of
corollaries.
I'm not aware of any direct treatment of TTP arising from either the COVID-19 pandemic or sickle cell disease. Broadly speaking, though, we're taking just the information, the knowledge that we have from sickle cell disease is that we do know that if we have optimized a patient with sickle cell disease, we've optimized their care in terms of their blood pressure, their diabetes, their other, if we've reduced the risk of other comorbidities by pneumonia vaccinations, influenza vaccinations, that it reduces the risk of relapse. So while we are always concerned about how do we treat someone with an acute vaso-occlusive crisis with sickle cell disease, along the lines we're also thinking, how can we prevent this from happening? And there's no reason that same sort of mentality, that same sort of thought process cannot be used with TTP. We're all very aware of plasma exchange, immune suppression, the use of caplacizumab in the treatment of TTP. But more importantly, I think now it should be, now that we've taken this acute deadly disease and turned it into a chronic condition, how do we prevent this from happening? And so for my TTP patients, making sure that they have been immunized, that we have all the other comorbidities taken care of, that we use this opportunity to prevent them from getting another relapse. Because a patient with TTP who then also gets COVID, if that COVID infection then induces another flare of a relapse of TTP, they will be in far worse condition than someone who didn't have, than if they didn't have COVID. I'm not sure if that answers the question, but that's how I would draw in from the sickle cell and COVID, that learning from those patients that whatever we can do to sort of reduce the risk of comorbidities of other diseases in TTP would be very beneficial.
All right. This patient wants to know, how do you get what is listed as a very knowledgeable hematologist who treats their immune TTP to understand that it's a chronic disease. And I guess what's occurring is they get discharged until they have an acute episode. Then when they have an acute episode, the hematologist follows them until they recover and then discharges them. So what would you say would be the best way to have a conversation about the need for chronic follow-up?
So I would say that it would be having a discussion with your hematologist. Again, this is a very rare disease, and so there's so many new research that comes up every year, which is one reason why we have a discussion every year where we bring people, experts throughout the country to meet, spearheaded by the USTMA and our patient education forum. But it's mainly to have a discussion with hematologists to share that new research coming up. There's more that's known about this, where there's cognitive defects, there's cardiovascular diseases, mortality could rise in survivors of TTP, and just to have a frank discussion why they feel the need to have a frequent follow-up. Again, for some hematologists, there are not many hematologists around the country who take care of TTP patients, and their clinics might be very full. And so when they feel that there is no acute need for your TTP, they might feel that you're better off served by primary care. And so a primary care can also do a good job, and there needs to be a collaboration between the hematologist and the primary care to make sure that all the rest of your comorbidities or preventive measures, like what Dr. Metjian had said, cardiovascular diseases, diabetes, hypertension, smoking, all those risk factors should be playing a role as how we take care of you in the long term.
Yeah, I agree. That's very little to add on that. I would also say for what it's worth, I've always told my patients that they are free. I mean, they should, if there's something that about me that they are not comfortable with. I'm not aggressive enough. I'm too aggressive. There has to be a proper fit, and it goes both ways. There's a fit between the patient and the physician, and if you don't feel that that is a proper fit, there is nothing that is preventing you from finding someone else. I mean, I agree, you already have a relationship with this hematologist. This is something you should talk about, that maybe you would prefer, you would recommend, you would want to have a more regular follow-up. But if that is not something that is something that can be agreed upon, there should be nothing that is stopping you from seeking out what you feel is best for you in that regard. And I would assume that most physicians do not mind. This isn't not going to be a slap in the face. This isn't going to be something that is thought poorly upon you. You should pursue what you feel is best for you. You should feel that is well within your rights to seek out someone with whom you feel most compatible with. That's my 2 cents.
And I think that the long-term management, the long-term follow-up of patients with TTP is a pretty new phenomenon. Certainly it wasn't that long ago where we didn't really understand that relapse was a common phenomenon. The long-term complications of this disease had not been described. And so it was pretty common that patients would be followed shortly after their episode and then and not necessarily followed long-term. And medicine is just in general is very slow to change. And so I think Dr. Metjian's comments about finding a hematologist who fits your style, is you can be a good advocate for yourself. You don't have to stick with the setup that has been arranged. And so, we welcome people to reach out to our group through our website. And we have connected patients with physicians with expertise in this disease. So I think it's important for patients to feel empowered to really take control of how their disease is managed.
All right. This patient was wondering, they had a TTP episode and they didn't have any noticeable long-term effects, like memory loss or cognitive problems. Is it safe for them to assume that those won't develop in time as long as they don't have another relapse, or is it possible for these to develop after an episode and it's been resolved?
So I would say that's a difficult question to answer, because issues like memory loss and cognitive defects, there are other reasons to develop them over the long term. I would say that it's worth knowing that there's always a possibility, But again, all the similar preventive measures all contribute to making sure that you don't end up having any long-term effects from your first episode of TTP. Again, having multiple episodes with relapses of TTP likely predisposes you to higher risk of developing the cognitive defects, but this is an area that is still being actively studied upon. As Dr. Mazepa has said, this issue of memory loss with TTP wasn't even thought about 5 years ago, I would say. And this is kind of research that's still evolving, research that's still ongoing, and we have people in our consortium that's actively studying this right now. So hopefully in the next few years, we may be able to better answer these questions. But right now I would say that not to focus on the TTP itself, but to, be proactive in preventative health measures, which will be beneficial overall for your health.
Right. I think that's understanding how many people have these problems and do they change over time is an area where there are a couple of studies ongoing. And we have to understand who those people are. So are there certain characteristics of those people? And what is the underlying cause of those memory problems before we can really address how to treat them? And I think that's one of the biggest challenges, because if we don't know what's causing this, we don't know how to treat it.
Or how to prevent it.
Or how to prevent it, right. So it certainly is great that you haven't had any problems with this complication, but I think it's still too early to really know what the chance is that you would have those kinds of problems. But we are actively studying this to try to figure those questions out.
All right, we have a question about the genetics of blood disorders. So this patient has TTP and their cousin has lupus and von Willebrand's factor disorder. Are you more likely to have a blood disorder if a family member has a blood disorder? Are you more likely to have TTP if a family member has TTP?
If there is, if someone had, if there's congenital TTP, we do want to know, of course, that it will increase the likelihood that this will be within the family, depending on where the family is. And so in that regard, there's more of a genetic component. Since there's a genetic component, we are concerned about the transmission of the mutations, the genes that increase the susceptibility for congenital TTP. For immune TTP, if there is if there's a strong family history of underlying autoimmune disease, particularly lupus, then we would not be terribly shocked if someone also developed TTP, but it's such a broad condition where lupus can be associated with many other autoimmune manifestations, many other systems within the body that can be affected. There's not a one-to-one correlation. And the ultimate pathophysiology of immune TTP, what is the reason that of all the enzymes in the body, of all the proteins that the immune system decides to attack this one specific enzyme, ADAMTS13, we don't know that. We're not that smart. We're not that good. That is the ultimate question of what causes the immune system, which is so good at not doing this. The one time that it fouls up, I'm not sure if we have got a very good answer for that. And I don't think I answered the question at all. Sorry.
Yeah, I think there is a familial. We certainly see that autoimmune tendency can run in families, and there is a relationship between patients who have lupus, that there's a tendency for some of those people to get TTP as well, and similarly, people who have TTP can develop lupus eventually. So there is a connection between those two diseases. Unfortunately, we don't really understand what genes are involved in the familial tendency to have immune diseases yet. I think that's a pretty complicated and very nuanced question, but like Dr. Mention said, it wouldn't be surprising to see someone who has immune TTP to have relatives with immune disorders, or they themselves have other immune disorders. Von Willebrand disease is a genetic disease. And in a sense, it's sort of the opposite of TTP. It's a deficiency of the sticky protein that causes bleeding. So there isn't, besides a similar protein involved, there isn't necessarily a connection between TTP and von Willebrand disease or necessarily other genetic blood diseases.
All right. If a patient has a refractory episode, is this indicative of imminent future relapse and or worse episodes in the future?
So if someone is in a refractory, meaning that ADAM-TS13 came down.
If the initial episode of TTP was refractory, like they had to go through multiple forms of treatment and they're in the hospital for a very long period of time, something like that, does that predict the future likelihood of relapse? And if so, are those relapses anticipated to be much more severe?
So there's two parts to the question. So the first question is, if your initial episode is refractory, would you be more likely to relapse in the future? That's a very good question that we're still trying to answer, I believe. A lot of our databases, we have are trying to answer these specific questions because we want to know, as physicians, we want to know which patient requires more close intensive monitoring and follow-up, and which patients you could, let them be and let the disease somehow resolve. Because we know that patients who get initial episode of TTP, only about, depending on numbers, up to 50% may have a first episode. Some people say lower than 30% may have a subsequent episode. So it's some reassurance to some of my patients, but some people are worried that it will recur again in a very near future. As for the second part of the question, how, if they were to relapse, would it be the same as the first episode? I would say it's most likely the case, but however, because we already know that the patient had a very refractory course the first time, as physicians, we're going to be a bit more aggressive. Well, let me correct myself. We'll be a lot more aggressive in treating the patient, that hopefully the refractoriness of the subsequent episodes will not be as severe as the first. Would that be a fair statement?
Yes. It is. I think what Dr. Lim mentioned is that every patient does not need the kitchen sink thrown at them the first time, and because you don't want to over-treat patients with therapies that are not necessary. If there's no benefit to something, then all you're doing is exposing that person to all the risks that are attached to it. But I think if I was in that position, if I was the hematologist and I had a patient who had a severe refractory initial course, and that person came back with a relapse of TTP, then yes, I am going to be much more aggressive than I would have been the first time around, because that is our mutual lesson learned. And I think part of the things that we've also learned is that patients, their second, third, fourth time around, it's not that it's not as bad as the first, but there's no surprise when they see it. Many patients can feel that something is wrong when they notice there's a bruise that shouldn't be there for no good reason. The barrier to getting another CBC has become orders of magnitude lower. And we're not seeing people who've been thrombocytopenic for a week or so because we can't. Is it ITP? Is it an infection? If this person whose platelet count, if your platelet count usually runs in the 200s and now all of a sudden it's 120, we are going to know what it is, and we're going to throw that person in the hospital, start plasma change, start high-dose steroids, start rituximab, start caplacizumab, and do everything that we can to prevent a reiteration of that initial event. It's a once bitten, twice shy.
Right. I mean, I think one of the big challenges is that with the first episode of TTP, that usually people are pretty healthy, and this comes out of the blue, and so it's very very surprising, and so can take a while to get a diagnosis, and patients can come in quite sick because they've been feeling not so well but not sick enough to come into the hospital. since they're not someone who regularly comes to the emergency department or come to the hospital. So I would say in general, we tend to see people be sicker with their first episode because they don't know what they have. And then with subsequent episodes, I usually tell my patients, remember how you felt with your first episode. Remember the days before you came into the hospital. Because when the disease, if and when the disease comes back, you'll probably have similar symptoms. And so I think we all generally see that with relapse that patients often come in earlier, and so their disease may be easier to control. So that's one strategy that hopefully we can prevent the next episode from being quite as difficult to treat as the first. But right, we would love to be able to predict how this disease behaves, but we cannot do that. I guess the good news is we're not seeing that people who had a first refractory disease always have refractory disease. There are very few absolutes in medicine. I think that's where we stand now.
All right, and this patient is referencing graphs shown earlier in the day. Interpret them to say that the younger you are in your initial episode, the more likely you are to have additional and more frequent relapses in the future. Is that correct?
I having not seen the graph, I think I can guess what that graph shows. But at the same time, it's more of a survivor bias. The longer you're alive for, the many years you're alive for, the odds of you getting another episode is going to be higher if you get it at 20 years old versus someone who gets it at 75 years old.
Yeah, and I think we have very few predictors of what the future will hold. We often talk about risk because we can't predict what will happen. So I wouldn't necessarily, I would say I'd follow someone who's younger any different than someone who's older. Because when we talk about what's the chance of a relapse, how do you interpret 20% versus 80%? It sort of depends upon your perspective. So yes, we are trying to figure out, obviously relapse is a big problem in this disease. We're still trying to figure out why relapses happen in certain people. So things about age, and we talk about risk factors for relapse, but what we're really trying to get to are what are those underlying problems that cause the relapse and looking for ways to jump in to prevent that relapse. But right now, again, we're not managing people of different ages in different ways.
And I wouldn't say that having the first episode of immune TTP at the age of 21 is somehow a poorer prognosis, somehow is going to portend a worse course of the disease than if someone had developed it when they were 81.
All right. There's a question about a medication called aptamers, TAGX-004. Will it be as effective at inhibiting thrombus formation as campylocizumab? Are you familiar with the medication?
Is it anifibotide?
It's APTANER.
Hold on, we're going to ask Dr. Google.
I'm doing that right now.
Not app. That's not.
Aptamer. I mean, it might be a specific aptamer. Just a.
Oh, okay. So the aptamer
Oh, sure.
No, it's an aptamer.
Well,
is TAGX-004. If you're familiar with it, we can talk about it. If not, we can move on.
yeah, so aptamers are a family of sort of drugs in development that are designed in a similar way to bind to specific proteins. So this is another strategy that would, I think, if I'm familiar enough with this drug, it's basically similarly blocking interaction between platelets and von Willebrand factor. I think at this point, we don't know, especially with new drugs in development. And we can't really compare. This is always a challenge in sort of new developing science, is that science always starts at the level of the bench. And we can't really tell just because a molecule behaves a certain way in a very controlled environment in the laboratory, how that translates into a better or worse treatment in humans or in certain humans compared to others. And so, for most of the work we do in our consortium is at the level of the patient. And so it's really hard to sort of say, because the results in the laboratory look better or worse than something else, how that's going to behave in a human. And that's why drug trials are designed the way they are. You'll hear phases of drug development, the standard phase 1, phase 2, phase 3. And so drugs are developed in this manner. They may be developed in a laboratory to show a certain possibility as a benefit to humans. They're tested for safety in phase 1, some evidence of effectiveness in specific diseases in phase 2, and in phase 3 generally compared against some sort of standard treatment. And the reason that we don't get new drugs until they've gone through all those 3 phases is because a medicine works in the controlled environment of the laboratory may have nothing to do with how eventually the results turn out in the large trials. And I think generally why we see a great deal of caution with regulatory agencies like the FDA here in the US is that it can be very hard to tell how much benefit one gets from medicine. Certainly, we don't want to cause any harm, but even then, sometimes long-term harm is hard to see in studies. So I would say even if we had this study about this medication in front of us, because it hasn't gone through all this testing, we can't really tell how much benefit it has in TTP until it really has gone through that kind of rigorous testing. And certainly I will say, while that probably sounds fairly negative, it's really exciting that new strategies and new drugs are being developed for this disease, because our toolbox was very limited for many years. So certainly exciting that new drugs are in development.
So an aptamer, this is an app tag 004 is an app.
This is the we used to know that this is the Japanese. The Japanese developed anyone that made aptamer for a couple of years. That's what this is.
Okay.
We study in Japan, but not outside Japan.
Okay. There had been a similar agent that Dr. Catalan is quite familiar with, an aptamer for TTP that was pulled off the market. Development was stopped. There is, for new TTP drugs, there is sort of a mirror image of caplacizumab, something called the anaphibotide, where instead of binding to the A1 domain of von Willebrand, it instead binds to the 1B9 receptor on platelets. So it's, yeah, and that I think has only had a phase 1 study. I don't think it's gone anywhere aside from that. There was a company that was looking into doing something called CAR T therapy for TTP. And I've not heard anything else since then, but I'm unaware of any other, in terms of the acute treatment of TTP, any other treatments that are out there.
Yeah, and I guess I would, as patients and family members are trying to look for what's coming in this disease, to just always remember that to take everything with a grain of salt about what you're reading, because what you may be seeing is a very exciting scientific report about a finding in the laboratory, and I think that certainly moves the science along to the next phase. But again, just because we see a certain result in a controlled laboratory environment, we can't necessarily take that and move it right into a patient and say there's benefit. So that's why there's all this rigorous testing of new medicines.
All right. Assuming proper diagnosis and treatment, do people with TTP have the same average lifespan as those without TTP, or is TTP inherently a risk for a shorter lifespan?
So I think most of the reports about mortality in this disease, are limited in a sense that they tend to be small reports. And I think this question has changed over time. And so there was a time when everyone with TTP died from the disease because we didn't know what caused it and didn't know how to treat it. And then moving into the 80s and 90s, we started to learn how to treat it. And then finally learned what the underlying cause is. So this question is a little bit of a moving target. So there are reports that say that patients with TTP have lived a shorter lifespan. I think what we're all hoping is that with better recognition of the disease and better treatments, that won't be the case anymore. So I said maybe that's the glass half full reply, but certainly that's part of the mission. If there wasn't a need to improve patients' quality of life and length of life, we wouldn't be here. So yeah.
All right. If somebody had their spleen removed, do you know what the statistics are down the road? Any studies at looking at whether there's relapse or if there's long-term complications from having the spleen removed?
The second part of that is kind of is well known because splenectomy for ITP for several decades, that was like the sole treatment. And splenectomy is also performed for many other reasons, such as trauma or other sort of surgical reasons. So I'm going to answer the second part because that's the easier one. We know that some of the long-term consequences of there's two big things that we are concerned about with splenectomy. The first one, which is the increased risk for infection, specifically something called post-splenectomy sepsis. And so for all of our patients, in that they're typically susceptible to what are called encapsulated, a certain type of bacteria. So we recommend that our patients get immunized against the pneumonia, with the pneumonia vaccine, something called flu or which is not the influenza, but Haemophilus influenza, which is another bacteria, and the meningitis shot. And that we also recommend that our patients, once they've gotten this, they also routinely get boosters for this. At the same time, we also counsel our patients that if they have an elevated temperature, that they need to get evaluated immediately. If they have a temperature of 101.5 or greater, and my patients usually have a bottle of Augmentin or a bottle of Cipro, depending on if they're allergic or not, to take just in case on their way to the hospital. So that's the first thing we worry about is post-splenectomy sepsis. The second risk that occurs with splenectomy is the increased risk of thrombosis, both venous and arterial. And that data has been out for quite some time. It's something that we're just cognizant of. We recommend low doses of blood thinners in settings of increased thrombotic risk, but those are the two. But an increased risk of infection, increased risk of blood clots are the biggest risk for splenectomies. As for whether or not it ultimately eliminates the risk for a relapse of TTP, I think the safest answer is we don't know. I don't think we've ever come to that point where we know for absolute certainty that we have eliminated someone's risk for relapse of TTP. Again, since this is now a chronic illness, we are not shocked. We're not surprised if it happens again. But certainly, the reason for doing a splenectomy is to markedly reduce that risk.
I'm just trying to think of all my patients. I only had one.
I've had only one
that I had a splenectomy on, because there's so many other treatments that we would now try. I just talked about besides rituximab, there's also Velcade, there's also cyclophosphamide and azathioprine. So there are a lot of multiple medications we would try first before we do splenectomy, because it's an organ that's pretty useful. So we try to avoid taking out as much as we can, but it is an option to try and reduce the risk of relapse in some of our patients in the future. But I personally don't have enough data to know what the risk of relapse would be after post-splenectomy.
Right, and I think that's the biggest challenge, is that there just isn't enough information out there. Can you have a relapse after having a splenectomy? Almost certainly yes, because I don't think we know how to cure this disease. And I don't know that if you didn't have a relapse after having your spleen out, I don't know that we could credit the having the surgery as having cured you. So there haven't been any large studies to try to answer that question yet. When we try to answer questions like how well a treatment works, we're often trying to compare one treatment compared to another. And I think the reality is that some treatments work better in certain people. And ideally, what we're trying to work toward is trying to understand how do we personalize our treatments? How do we figure out which treatments work best for certain people? Because the reality is that there probably isn't one perfect medicine for everybody. It's really, we have to try to eventually figure out what works best for which patient. So splenectomy certainly is a treatment that has been used to treat this, but less commonly since we've gotten better medications.
All right, this patient is a recurring relapser. They've had serious issues and they're having chronic complications, and they feel like they're being dismissed by the physician. What have you guys experienced as some of the long-term complications of a chronic TTP patient? And how are they best explained to the medical community, and what treatments might be available to help alleviate the symptoms of long-term complications?
Yeah, so I think one important question is why do you feel like your physician is ignoring it? And I think one of the biggest challenges for us is that we don't really have any specific treatment to offer besides offering our support, because we don't necessarily know exactly what causes some of the problems with memory and depressed mood and things. The other part is the physician may not know that these are common long-term complaints. So I think that may be part of the reason why you're feeling that way.
Do you ever use like antidepressants? Would you treat them the same as any other patient that came in and expressed feelings of depression or anxiety?
I mean, I would do assessment to make sure, PHQ-9, do a proper history. And then if I'm comfortable that this is a diagnosis of depression, then yes, antidepressants is the way to move forward. Yeah.
Just to take a step back to clarify that this is, someone may have TTP, may go through, maybe in the throes of the becoming diagnosed, being thrown in the hospital, getting plasma exchange, high dose steroids, and then the TTP itself can pass. And then what's left is the after effect. The analogy I use with my patients, it's like having hot grease go on your arm. You can wipe it off right away, but the lasting, the effect stays for quite some time. And I think now, so I think we shouldn't, there might be some clarification that this may not be, if the TTP may have resolved, but the after effects still remain. And a theme that has come up is that this is something that we're still learning to deal with. We had the luxury of our patients living long enough to see what were the after effects of TTP. So having rates of depression, anxiety, post-traumatic stress, where I've had patients who are sweating and anxious and nauseated because they're coming back into the hospital because their last visit was so distinctly unpleasant. We're still learning, and I think, I think what I said before, if you don't feel that you are getting the care that you need, if you don't feel that you are getting the support that you need, please go get it. Find someone else who will listen. It doesn't have to be a hematologist. If you're having issues with anxiety, you're having issues with depression, if you're having issues with memory loss, these aren't the sole domains of a hematologist who treats TTP. Your primary care physician, your OB, your gastroenterologist can easily send you to someone if they know someone who's a great therapist, refer you for neurocognitive testing so that you can get the help that you need. That's something that is easily that can be within your grasp. It's not something that has to comes solely from your hematologist.
And I do think that maybe I mentioned before, is it not recognized by your hematologist? Is it the sense that your hematologist doesn't know how to treat it? But it may be that your hematologist feels that it's in the domain of your primary care doctor. So I completely agree with Dr. Metjian that be your own self-advocate, and you know, I would say reaching out to your primary care doctor may be kind of the next best step.
Mhm.
And have both of them talk to one another, because the primary care doctor may not be as familiar with TTP, whereas the hematologist is familiar with TTP, but may not be up to date with the best treatment for cognitive function or best treatment for antidepressant, because medicine changes so often that it can be pretty hard to catch up. But it's more important to have the connection between the primary care doctor and the hematologist and have them talk to one another to at least share the education that they both have and to discuss your case in a more informative and collaborative effort to take good care of you.
Well, I think that is a perfect segue into our next session, which is coping with chronic illness. Thank you to our panelists, for everybody who's joined. I know there is more questions that we did not have answered. We will do our best to try and answer them sometime today. Otherwise, we will attempt at our next Ask the Hematologist, or if you feel like you really want to answer for that, just send us an email and we'll get you a response. So thank you, everyone.